So this is what I'd like to do today is give you a quick overview on some of the trends on the epidemiology of HIV infection, both globally and locally. Understand a little bit behind the multifaceted reasons that are relating HIV to an increased risk of cancer, and review new modalities available for the diagnosis of HIV. We'll talk a little bit about the options available for prevention of transmission in discordant couples and how that impacts the size of the worldwide pandemic. We'll review the risk and benefits associated with early therapy for HIV and go over some of the salient aspects of the guidelines for the treatment of HIV infection. So I'd like to start with this study. This is HPTN 052. You're all very familiar with this study. This study had a DSMV evaluation in 2001 that resulted in cessation of the study because of added benefit from introducing early antiretroviral therapy, and subsequently went on to have an update. So let me walk you through that because I think this is a real important and seminal study on preventing transmission of HIV infection. So this study included stable, healthy, sexually active HIV discordant couples with CD4 counts from 350 to 550 CD4 T cells, and randomized them to two groups. One was the early antiretroviral therapy, in which 886 couples initiated antiretroviral therapy immediately, and the second group with delayed antiretroviral therapy, with the triggers being a CD4 count to less than 250 cells or developing of an opportunistic infection. During the first 6 years of the study, it was noted in one of the DSMV evaluations that the individuals randomized to the delayed group had an excess of linked HIV infections. And you can see here in the early antiretroviral therapy, only one linked infection occurred, and this is based on molecular typing of the virus, compared to 36 in delayed therapy. And at that point in the study, individuals in the delayed arm were transferred over to the early intervention arm and continued to be followed through cessation of the study in 2005. And what you can see here is for those randomized to the early group during the first half of the study, 97% of individuals on therapy were protected of linked infections. And when you add the second half of the study, being on antiretroviral therapy prevented the discordant couple from acquiring HIV and 93% efficacy, which is quite dramatic. So taking these numbers, UNAIDS has looked at some of the goals for treatment and containment of HIV. And they've proposed two scenarios. The so-called no scale-up scenario, where you maintain the 2013 coverage levels for antiretroviral therapy worldwide. And what they predict with this is a curve that looks like this in terms of new HIV infections, and a curve that looks like this for AIDS-related deaths due to HIV infection in low and middle-aged income countries. Now, if there is a rapid scale-up of therapy, meaning that by 2020, 90% of individuals with HIV are diagnosed, and 90% of them go on therapy, and 90% achieve viral suppression, the curve would be dramatically different. 21 million AIDS-related deaths would be averted, 28 million people living with HIV infected would be prevented. There would be 5.9 million less infections in children, and the return on investment in terms of dollars would be 15-fold higher. So the goal by 2030 would be to achieve 95% in each one of these three arms, leading to a worldwide incidence of 2,000, 100,000 new infections per year. So very lofty goals that UNAIDS tries to achieve. And so these are their treatment targets. Estimated currently 36.9 million people with HIV infection worldwide, of which 33.2 would need to be diagnosed, 29 million would need to be on antiretroviral therapy, and of these, 26.9 million would require to be suppressed. So what are the gaps now in terms of this continuum of care cascade? Currently, it's estimated that 19.8 million people are diagnosed, so the target is reached in 53%. It is estimated by 2015, 15 million individuals will be on antiretroviral therapy, and currently 11 million are suppressed worldwide. So still some significant proportions of individuals that would require to be managed through the chain of HIV care. Now, these are the numbers of people on antiretroviral therapy tracked from 2005 to June 2014 for all countries. And for June 2014, approximately 13.6 million people have been receiving antiretroviral therapy. The target being 15 million for 2015, and hopefully that will be achieved to keep in that model of 90% diagnosed, 90% treated, and 90% suppressed. Now, this is coming at an incredible cost. If you look at the money that's been poured into HIV care from the beginning of the epidemic up until now, it's just astonishing. $19.1 billion invested in programs in HIV in 2013. And again, remember that the return on investment in terms of lives saved and productivity would be 15-fold if targets are continued. So what's happened more locally in the United States? In the US, currently we think 1.2 million people are living with AIDS, or HIV infection rather. 156,300, or 1 in 8, are unaware of their diagnosis. As Dr. Vierling mentioned, the numbers are not as high as with hepatitis C, and some people tend to think that this is actually an overestimate. In 2013, we had 47,352 new cases of HIV and 26,688 individuals were diagnosed. So if you look in the past 30 years of the pandemic, in the US, there have been approximately 1.19 million individuals diagnosed with HIV/AIDS and 658,507 deaths. So continues still to awe in terms of just their numbers. Now, how does our continuum of care compare to those worldwide targets? In 2009, 85% of individuals thought to have HIV had been diagnosed. That's remained flat. We still are missing that 15% of individuals that are required to be diagnosed. But more worrisome is the fact that many, although they have received some form of medical care, are not completely suppressed. And studies show that in the US, approximately 30% of individuals diagnosed and treated with HIV have achieved viral suppression. There's still a long ways to go in that setting. Now, where is it that this spectrum of care is interrupted? These are estimates from the CDC in 2013, looking at total number of HIV-positive individuals diagnosed, the risk factors for each one of the groups, as in terms of whether they had medical care within 3 months after diagnosing HIV. And you can see that a good number of individuals drops off to follow up with that first initial contact with the healthcare system. So an example of this is a paper that was published just a few weeks ago online, looking at this landscape in North Carolina. It's a database study that is looking at tracing active transmission of HIV, looking through several ongoing public health programs, as well as a surveillance for a vaccine study. And what they did is they linked individuals who had been diagnosed with HIV and attempted to contact their contacts, and then performed a serological algorithm to determine whether these were recent infections or not. And in a subset of individuals, completed molecular studies to looking at the linkedness between the newly diagnosed case and the contact. And so what they have is this STAT program looking at acute HIV infections diagnosed during the study period, 358 individuals. That named their partners, most individuals with at least 1 to 2 partners. And looking at the comparisons between both groups were quite similar. And this is the subset of individuals for which linked genetic studies were done that were followed through this prospective vaccine study. Now, this group, the CHAV1001, belongs to the STAT cohort. So they're not necessarily mutually exclusive, but they're separated here since they are the ones that had the molecular-based studies. And when you look at these individuals, and I'll just focus on the ones that were genotyped, it mirrors the proportions of the overall study. 367 total partners, 78% of these were determined to be anonymous. That is, the person with acute HIV infection only reported anonymous sexual contact, and 289 for which a contact investigation was initiated. For those that contact investigation was successful, 119 were already known to have HIV. 126 were not known to be HIV infected, and 44 had unknown studies. And of those that were known to be HIV infected, 26% of them had chronic, I'm sorry, not 26%, 26 individuals had chronic stable infection and 11 acute HIV infection. And so when you look at the results of the study, 74% of the contacts that initiated the transmission of HIV had already been diagnosed with HIV. 5% of them transmitted HIV while having an acute infection, and 20% of these were unaware of their diagnosis. And if you look at the attributable transmission, 77% of all new infections acquired in this particular cohort came from individuals that already knew they had HIV, but were not necessarily on therapy. And only 23% of these were actually, about 23% were actually suppressed. So what's more interesting too, when you look at the phylogenetically linked cases, again, proven by molecular techniques that support the epidemiology observation, is that 60% of the individuals that transmitted HIV had already been previously recognized in the system and diagnosed. So still a long ways to go. This is another very interesting study that came out that tells us of some of the barriers that we find now in managing HIV infection. So in January of this year, the CDC began a new investigation in a rural community in Indiana. They found that the healthcare providers there had reported 11 new infections with HIV, when the historic control was only of 5 cases per year in the Southwest Indiana. Most of these were white with a mean age of 32. By June, this is only 6 months later after the investigation was initiated, 169 cases of HIV had been identified in those 6 months. And very worrisome, 80% of these were found to be co-infected with hepatitis C virus. When they looked at the individual risk factors, an important mode of transmission, including IV drug use, the use of oxymorphone and heroin, and sharing needles. And most of the individuals that acquired HIV shared a mean of 9 users per needle. So a very sought-after item in this particular community. And 7% of them were sexual workers. There were a few pregnant women. Luckily, there have been no vertical transmissions to date. So this is an example of how we have regional hotspots with high bloodborne virus transmissions that are multifactorial. If you look at what the issues were with this particular community, the Planned Parenthood clinic in that town, which is the only HIV public clinic in the area, had been recently closed, and there was no way for people to get an HIV test for free. There's also been a dramatic shift in the drug availability. There is an ongoing epidemic of IVDA in the US. And as you can see, there has been a dramatic increase in the number of heroin overdoses, which has gone up 280% from 2010 to 2013. Other considerations that are responsible for this type of scenario is the lack of needle exchange programs. The state of Indiana did not have a program. They emergently approved that through the state Congress in Indiana. And fortunately, in the state of Texas, this has now been passed through Congress in May 2015 and will be instituted statewide. The only needle exchange program currently available that I know of is in Austin, but it will be good that there can be an effective needle exchange program, as this has shown dramatically to decrease bloodborne transmission of HIV through IV drug units. Another consequence of these lack of needle exchange programs can be exemplified by this statistic. If you look at the IV drug use acquired hepatitis C cases have increased nationally, and there are certain areas, for instance in Appalachia, where there's 56,000 cases of hepatitis C ongoing in the state of Kentucky. So a lot of work needs to be done in those areas. Well, let me shift a little bit more on some recent data in some epidemiological studies with HIV and cancer. Now, I put together this slide from three major sources. The references that are listed there, but also from a request from applications of the NIH or the NCI that is looking for new applications and new what they call innovative ideas in HIV and cancer. So most of the cancers that occur in HIV occur because of oncogenic viruses. Classical examples being Kaposi sarcoma and EBV in the setting of T-cell loss. But we also know that even in controlled or slow progression, HIV results in chronic inflammation. And this impacts the risk for other, for instance, hepatitis C, liver-associated cancer, lung cancer, lymphoma, and Kaposi sarcoma. Now, it's been hypothesized that HIV can cause cancer directly. We know that the TAP protein from HIV encodes factors that promote angiogenesis, particularly when co-infection with Kaposi sarcoma herpes virus in individuals that are known to have high IL-6 genotype. And furthermore, that once you control HIV and you restore the immune system, you can control those tumors. There is the hypothesis also that HIV integrates into oncogenes or tumor suppressors and can disrupt their function, therefore facilitating oncogenesis. We know that HIV is also frequently associated with other cancer risk factors, such as smoking, HPV infection, and anal receptive intercourse, again, a risk factor for Kaposi sarcoma. Curiously, HIV has been associated with protection from some cancers, particularly breast and prostate, and that has been shown across several studies. And importantly, too, individuals with HIV and cancer have different tumor types than individuals who are non-HIV infected. For instance, the mixed cellularity versus nodular sclerosis and HIV-negative lymphoma. We also don't know the long-term effects of antiviral therapy and aging in HIV and cancer. And many of these infected patients have health access disparities and lack of comprehensive care, which increases the risk of uncontrolled infection and presumably access to cancer screening. So this is a study that looked at the incidence of solid tumor cases at the stage of diagnosis in patients infected with HIV and transplant recipients. And what these investigators attempted to do was contrast two immunosuppressed populations and looking at their risk for HIV infection. So at the risk for cancer. So they examined 15 cancer types from 2006 to 2010 in 2 US cancer registries. So that included in HIV 8,411 cases of cancer out of the database with 4.5 million. And for the transplant, 7,322 of 6.4 million cases. The estimated odds ratios for advanced disease comparing the HIV and the transplant individuals, adjusting for other variables such as age, sex, race, registry, and year. And what they found is that in HIV infection, there was a higher incidence of oral, pharyngeal, anal, liver, lung, cervix cancer with lower breast, uterine, prostate, bladder, and kidney injury, or kidney cancer. And when compared with immunocompetent patients with cancer, HIV patients were more likely to have metastatic or advanced stage lung cancer, advanced or metastatic female breast cancer. Remember, it's protective overall, but not necessarily of its progression, and prostate cancer. In contrast, the patients on transplantation had fewer distant stage lung, breast, and prostate cancer. But what's interesting, too, was that in both immunosuppressed populations, melanoma appeared to be diagnosed at a more advanced stage, as did bladder cancer. And they conclude that these is likely the effect of differences in healthcare access, differences in screening habits, and immunosuppression of the population. In this study, what was found also was an increase in the adjusted cancer-specific mortality related to colon, lung, melanoma, and breast cancer. In this abstract presented in CROI earlier this year, a case control cohort study compared the incidence of cancer cases in the cancer registry and sampling 5% of the Medicare population aged over 65. And they compared 823,450 cancer cases compared to 469,954 controls with and without HIV. And what they found is in this elderly population, a cancer diagnosis was made in 2.5% of individuals over a 1-year period of time, and in 10% over a 5-year period. So the hazard ratios for non-Hodgkin's lymphoma was not as high as seen in other studies because the non-Hodgkin's lymphoma incidence is naturally higher in elderly patients. So what else is new out there in HIV care? Also this year, there's been the approval of a new HIV screening test. There's now a 5th generation HIV tool that detects both HIV antigen and antibody, allowing for an earlier diagnosis in acute HIV infection. But now can report separately the P24 antigen for HIV-1 and antibodies for HIV-1 and 2. As you may recall, if you wanted to differentiate whether you had HIV-1 or 2, you had to do additional testing. Now with the 5th generation diagnostics, you can diagnose both HIV-1 and 2. It has a very high specificity in low-risk populations. It's currently approved as a quick diagnostic for organ donor screening and also as a backup for blood and plasma donors for urgent situations. Well, you might be asking yourself, why would I want to test for HIV too? This is just to remind you, most commonly found in West Africa, in Senegal, Gambia, and Guinea-Bissau. There's about 2 million cases worldwide, and it's biologically quite different. It replicates at a lower rate. It uses chemokine receptors in a much more promiscuous way. There are many other types of cells that can be infected by HIV. Commercially, we cannot measure viral loads for HIV-2. It elicits a broader immune response and has lower markers of activation. It has a higher number of long-term survivors, but it progresses at higher CD4 counts. So you'll see these patients with pneumocystis pneumonia with CD4 counts of 400 or so. It's not susceptible to NNRTRs. It's not susceptible to fusion inhibitors. And the tropism assays are not fully developed, mostly because of this promiscuous co-receptor use. When exposed to antivirals, it doesn't follow the usual patterns for RTIs in that it does not develop the typical TAMs and is more susceptible to developing the K65 mutation, which is vital for tenofovir use. Now, importantly also, HIV-2 naturally is polymorphic in the protease inhibitor gene. You want to avoid atazanavir, imprentavir, indinavir, nilfinavir, and trepanavir because they're not as active as lopinavir, darunavir, and sequinavir. And remember that you can have both HIV-1 and HIV-2 co-infection. And I think as these tests get started being used a lot more routinely, we will start noticing that a sizable number of our patients may have HIV-2 in the US. Well, if you want to take home one message from tonight, is that who should be treated with HIV? And that is nowadays everybody. And I'll tell you a little bit as to why we feel this, that this is so important. Early HIV therapy has many potential benefits. It delays the progression of HIV-associated nephropathy, the progression of liver disease from hepatitis B or C, decreases the cardiovascular risk, decreases the occurrence of AIDS-associated and non-AIDS-associated malignancies, prevents the neurological decline, and it avoids the blunted immunological response that you end up having if you start antiretroviral therapy at older age. And it also blocks this persistent T-cell activation and inflammation. But importantly, it prevents the sexual transmission of HIV, and as you all know, the perinatal transmission of HIV. And a seminal study this year that is finally turning the tide for this is the START study. This is a very important study that's worthwhile delving into the details. This is a study that was an international study, 4,685 patients with CD4 counts over 500. They were randomized to either immediate antiretroviral therapy or deferred ART therapy. You can see the very comparable sizes. It was across 215 sites in 35 countries with a mean follow-up at 3 years. And on treatment, at the time that the DSMB stopped the study, 98% of individuals in the immediate antiretroviral therapy were on drug, compared to 48% in the deferred treatment. The study commenced in 2009, and the regimens used mirrored those that the Department of Health and Human Services had issued. Most common regimens were efavirenz, tenofovir, and FTC. However, there was a higher proportion of elbigravir and cobicistat in the deferred group. The reasons for antiretroviral therapy in the deferred group are in my view, very important to spend time on, because they really modified the frequency and incidence of the primary and secondary endpoints, which were either a decline in CD4 or progression to a serious AIDS or defining illness, or any AIDS-defining illness. And I'd like to draw your attention that a sizable number of patients in the antiretroviral therapy group that was deferred initiated antiviral therapy for reasons that you typically would not think. Patient's wish, clinician call to decrease the transmission of HIV, and really we're not hitting those hard endpoints. And the conclusion of this, in my mind, is that if individuals were allowed to progress as the study was originally designed, the impact of starting early antiretroviral therapy would have been more dramatic. So keep that in mind as we go. So when you look at the primary and secondary endpoints, you have serious AIDS-defining illness and serious non-AIDS events, including deaths from things other than AIDS or cardiovascular disease, liver or renal cancer, or cardiovascular events, as well as liver failure and end-stage renal disease, or having a non-AIDS defining cancer. And as you can see here, for the overall study, there was a significant 57% reduction in serious events or death. That's a 4.1% versus 1.8% in the deferred versus the immediate arms. So a quite dramatic reduction. Now, as infectious diseases specialists, we are interested in how these therapies prevented infections. The study was predominantly done in Africa, and it's not surprising that most of these opportunistic infections diagnosed here were pulmonary TB and extrapulmonary TB, but importantly also Kaposi's sarcoma. Now, being in MD Anderson, it's important also to look at how initiating antiretroviral therapy in this group might have prevented the occurrence of malignancies. And you can see also here a significant difference, a decrease of 64% in the hazard ratio of developing a malignancy if you went on immediate antiretroviral therapy. And you can see the types of cancers that are identified here. When you looked at the subgroup analysis, no matter how you sliced it, it tended to benefit all subgroups, regardless of their viral load and ethnic or racial background. Another study that reinforces this is an early intervention HIV therapy study where people were randomized to receive ART plus minus INH for prevention of tuberculosis. Most of the patients received PCP prophylaxis when they had a CD4 count of 500 or less. And what this study also showed is a 44% lower risk of severe HIV-related disease and 35% lower risk of death. So initiating antiretroviral therapy and tuberculosis preventive therapy in individuals with CD4 counts of over 500 is also a bit of benefit in areas that are highly endemic for MTV. So who are the patients that we want to initiate antiretroviral therapy immediately? So these are individuals that are pregnant, they have an AIDS-defining condition, they have an acute opportunistic infection, they have lower CD4 counts, and they have acquired an acute or recent infection. We worry about individuals that have a rapid decline in CD4 counts and have a higher viral load. HIV-associated nephropathy is also an indication for rapid initiation of antiretroviral therapy, as are hepatitis B and hepatitis C infection. This is a list that contains all the antiretroviral drugs that are currently available. I've crossed out the ones that are not really relevant anymore nowadays, and I've left those that are used in clinical practice in yellow. The recommended initial regimen based on the more recent guidelines have stressed a lot of importance on the integrase inhibitors, be that dolutegravir or bacavir and 3-TC. However, that should be done only in HLA-B5701 negative individuals. The combination of dolutegravir, tenofovir, and FTC, or elbigravir, cobicistat, tenofovir, FTC. Again, because of the potential toxicity to the kidney, should only be used in individuals with creatinine clearance higher than 70. And the older or first integrase inhibitor, raltegravir, in Truvada. The other initial regimen recommended is a PI-based regimen with darunavir and ritonavir with tenofovir and FTC. Many of these results come from the Flamingo study that shows the higher efficacy of dolutegravir, and this updated report that follows individuals at 96 weeks of therapy. A viral load that was undetectable was found in 80% of the dolutegravir arm compared to 68% in the darunavir arm. And with low rates of virologic failure and a minimal increase in creatinine clearance that occurred early but remained stable at 96 weeks. Another integrase inhibitor combination with cobicistat, tenofovir, and FTC was reported recently also in a WAVE study, which is a study done entirely in women, again showing the superiority of elbigravir compared to atazanavir in this population. Alternate regimens, efavirenz, tenofovir, and FTC. There are no NNRTIs as a first recommendation. Rilpivirine, tenofovir, and FTC, again for individuals that have a viral load less than 100,000 and CD4 counts over 200. And a number of PI-based regimens, atazanavir and cobicistat, a newly introduced drug that Ben Barnett will be expanding on in his presentation, as well as atazanavir, tenofovir, and FTC. There are a number of other options for alternatives to therapy that may not be as potent or limited because of potential side effects, such as raltegravir, abacavir, and 3-TC. and NNRTI-based regimens of efavirenz and ABC3TC, again, for HLA-B5701 negative individuals, in the protease inhibitors that are listed. So just to recap and to close this part of the presentation, as you select an antiretroviral regimen for your newly diagnosed HIV patient, look at their CD4 counts. If they're less than 200, do not use rilpivirine-based antiretroviral therapy or darunavir plus raltegravir. They're not potent enough to increase CD4 and contain the virus at this point of immunosuppression. For individuals with HIV RNA over 100,000 copies, do not use rilpivirine-based antiretroviral therapy, abacavir 3TC, and efavirenz or atazanavir. And again, darunavir and raltegravir not potent enough for individuals with high viral loads. For the HLA-B5701 patient, there's a contraindication for the use of abacavir, and all newly diagnosed patients should be diagnosed or should be tested for their HLA-B5701 genotype. And if you feel that you must treat before resistance tests are known or your genotype is known, you want to avoid an NNRTI-based regimen because transmitted resistance is more likely than with protease based regimens or with integrase-based regimen. You have a number of one-pill regimens now that increase adherence, dolutegravir, abacavir, and 3TC, efavirenz, tenofovir, and FTC, elbigravir, covistat, tenofovir, and FTC, the quad pill, and rilpivirine, tenofovir, FTC, again with their limitations. Keep in mind some of the side effects or some of the variability in absorption related to food. Efavirenz requires an empty stomach, whereas most of the other regimens should be taken with food. For patients that have chronic renal insufficiency, you want to avoid using tenofovir. If the GFR is less than 7, you have a number of options listed there with the quad pill, atazanavir, tenofovir. Do not use tenofovir containing regimens, essentially. And you have other options, some of which can spare the use of NRTIs. What I'll do in the interest of time is stop here so that we can have Ben Barnett come down and walk us through the patients that are already a little more experienced with HIV therapy and that are failing these regimens, and also to talk a little bit about newer agents down the line.